7-year-old boy is being referred for the evaluation of short stature. Weight is all right, but height is less than -3 sc. So the born age is compatible with the chronological age. So what is the likely action? So if you can actively participate, that would be beneficial for you all as well, for me also. So here, so the born age, you can check 3 conditions based on the born age. Born age coupled with chronological age means it's familial. If born age is uh, delayed but compatible with height age, that is constitutional delay. If born age is markedly delayed, even more than the height age, right? Even more than the height age, then that is some pathological condition like growth hormone deficiency or hypothyroidism. So born age compatible with chronological age means this child's growth potential is not blunted. So that is his growth potential. That's why this child is short, but potency is there. So that's why you call familial short stature. Right? Any questions? Uh, right. I hope you can see this. An 8-month-old girl presented with a history of fever and cough for 5 days duration. Diagnosis was made as pneumonia. She was started on IV antibiotics. So what happened? The scenario here is mainly the girl with severe acute malnutrition or undernutrition. So severe acute undernutrition presenting with pneumonia. So that means stable patient. So nutritional rehabilitation should be started with reduced synthetic food. The best therapy RTF would be, because in this kind of a case you have phase called stabilization and then the rehabilitation part. So these kind of children, in order to prevent refeeding syndrome, you have to start them with low calorie dense RUTF, called F75 is the answer. If this child has no complications, if this child was referred to your clinic as an outpatient, then the answer would be BP100. If this child was on F75 for some time, and then now I'm telling you, we can set up 5 questions based on this. So I can give separate another 4 questions to have correct answers. Like now this, in this question the correct answer is F75, but I can set up a question B to come BP100 as the correct answer, likewise, right? So triposure is indicated if there's moderate acute malnutrition. So the one, a 9-year-old girl presents with anemia and jaundice. That means hemolytic anemia. He had 2 similar episodes in the past. That means episodic hemolysis is going on. He never received a blood transfusion. On examination, he has 3 centimeters splenomegaly without any hepatomegaly. What is the most likely diagnosis? So this has to be a case of extravascular hemolysis, which is recurrent, not trans-dependent. So let's see what are the causes. So G6PD deficiency is unlikely due to 2 reasons. One is being a girl. G6PD is a X-linked recessive one. G6PD you don't get splenomegaly because it's intravascular hemolysis. Hemolytic uremic syndrome also don't get splenomegaly. Hereditary spherocytosis is a possibility to get jaundice and anemia. Fanconi anemia is not hemolytic anemia, so you can exclude it. Thalassemia major will not have this presentation, because if you get a child with thalassemia major by 9 years of age, that child would have had multiple blood transfusions. So the answer is hereditary spherocytosis. Right. So an 18-month-old boy presents with tender swollen right knee joint. He has got multiple bruises over both shins. Mom claims that he has got easy bruising. Clotting profile is as below. PTINR normal, APTT high, bleeding time, clotting time normal. So this is very easy. So non-accidental injury is out, because in the presence of high APT, that's out. Chronic liver disease you can definitely exclude, because in liver disease PTINR is high. So then glass mass thrombasthenia is a functional platelet defect disorder in which you have elevated bleeding time. So you can exclude that. So you are left with hemophilia and von Willebrand disease. So in both conditions you can have this picture, but being a boy and in von Willebrand disease, there's some platelet functional problem also, other than high APTT. They will have bleeding, prolonged bleeding time as well, and also classical joint bleeding. You can get it in both conditions, but with the given context, with normal bleeding time, with isolated high APTT, hemophilia is the answer. If it is a high APTT with high bleeding time, then it would have been von Willebrand disease. If PTINR normal, APTT normal, clotting time normal, blood bleeding time is high, then the answer would have been glass mass thrombasthenia. So likewise, so the same MCQ, you can have 5 versions of it. Right. Can you all hear me?
Yes, sir. Yes, sir.
You are following me, are you?
Yes, sir.
Okay. If there's any question, just oh, after question number 4, it's question number 6. I think there's a mistake, so you'd have got only 14 questions in that case. Right, anyway, that's fine. A 5-month-old girl presents with poor head control, examination alert, but has got generalized hypotonia. She has got respiratory distress with funnel-shaped chest. The lower limb reflexes are absent. So this is a girl with weak floppy. That means it has to be a lower motor neuron lesion. So I have given 5 possibilities for lower motor neuron type lesions in children. So Guillain-Barré syndrome, polio, spinal muscular atrophy, Duchenne muscular dystrophy, and myotonic. So out of these, muscular dystrophies will have preserved reflexes until very late stage. So dystrophies have reflexes. So you can mark that. And also being a girl, Duchenne muscular dystrophy, you can exclude because it's an X-linked recessive. So then you are left with Guillain-Barré means nerve condition, neuropathy, and polio and spinal muscular atrophies are anterior horn cell diseases in children. So this child has got funnel shaped chest and respiratory distress. And alert means out of these 3, this child has got features suggestive of spinal muscular atrophy or Wernicke-Hoffmann disease. Right? In best of 5, so ABC, all 3 answers are ability, but the like answer would be muscular atrophy or Wernicke-Hoffmann disease. So type 1. Then Question number 7. A 3-day-old baby presents with fever and irritability. Following the initial evaluation, the decision is made to start him as for neonatal meningitis. What is the most appropriate antibiotic combination? Sepsis and neonates can't say two different things, but when it comes to antibiotic choice, we have to select different antibiotics. So if it is neonatal sepsis only, not thinking of meningitis, then the antibiotic of choice would be ampicillin plus gentamicin. If we are thinking of neonatal meningitis, so the antibiotic of choice would be ampicillin plus cefataxin. So answer is B. We don't talk about meropenem, and we never give ceftriaxone in neonates because high bilirubin is a contraindication to start ceftriaxone. So anything start with ceftriaxone, we can omit. So we don't usually give aminoglycosides and cephalosporins together because both will cover mainly gram negative. So ampicillin, gram positive cover is important to cover listeria. So ampicillin should be there and cefataxin should be there if you are covering meningitis. If it is neonatal sepsis, you can get another question like this. If it is neonatal sepsis, then Genta plus ampicillin. A 2-year-old boy developed sudden onset cough while eating chickpeas. He had vigorous cough initially, but within a few seconds he turned blue and has no effective. It has to be no effective cough. However, his consciousness is preserved. What is the most appropriate management? This is exactly to follow the algorithm. So, choking child, you have to differentiate if the child has got effective cough or not. If there's effective cough, encourage cough. If there's no effective cough, you have to see whether the child has got consciousness or not. If there is consciousness, then you give 5 back blows. If there's no consciousness, then you start cardiopulmonary resuscitation. So that means the answer is give 5 back blows. After you give 5 back blows only, you start 5 chest thrust. You don't start with chest thrust at the beginning. So the answer is B. Right. 10-year-old boy with sudden cardiac arrest while in the ward. He was intubated by the anesthetic team and chest compressions. Given 1 cycle of cardiopulmonary resuscitation. His cardiac rhythm showed asystole. What is the next best option? So, cardiac arrest, you can have 4 rhythms. Asystole, pulseless electrical activity, one category, and VT and VF, the other category. So, in VT-VF, cardioversion is the treatment, but if it is the other way, IV adrenaline is the answer. So since this one has already received 1 cycle of cardiopulmonary resuscitation, so straight away you have to start IV adrenaline rather than continuing another cycle of CPR. So after that, every other cycle of CPR, you give adrenaline. Just follow the algorithm. Then the question number 10, a 2-year-old boy presents with a history of fever and cough 2 days with soft stridor. On examination, toxic and having hyperextended neck, what is the most appropriate management? This is a very common question. So soft stridor is not a feature of croup. Harsh stridor is the feature you see in croup. So this is not croup. So this is epiglottitis or bacterial tracheitis. But unless proven otherwise, you have to treat these 2 conditions as epiglottitis, because in bacterial tracheitis you will have to give them intravenous antibiotic. Even in epiglottitis intravenous antibiotics are indicated, but soon after you disturb the child, they will develop airway obstruction. Because of that, you should not touch these children. It's easy in a way. It's matter of calling the ENT team and anesthetist to intubate this child, or under direct vision them to examine with airway management. So ENT is the answer, and anesthetist. Right. A 6-week-old baby presents with poor feeding and excessive crying one day. On examination, heart rate 300, ECG shows narrow complex tachycardia with absent P wave. So this is child with SVT. So, but rest of the circulatory parameters are stable. So in SVT, the algorithm is stable SVT and unstable SVT. Stable means with the normal circulation. So if the circulation is normal, then you start with vagal maneuvers and adenosine. If child has got shock, then the cardioversion. So eyeball pressure is a form of vagal maneuver which is contraindicated in children. You can do it in adults. Start Valsalva maneuvers is something which is recommended, but you can't do it in this age. Applied cold water filled rubber glove over the face is the practical way of putting ice over the face. And start IV adenosine is not wrong, but we have to do it after we DC shock is true but not indicated now if they have circulatory collapse or shock. Right. So then dermatology question. A 1-month-old baby was diagnosed to have scabies on his face. What is the best pharmacological treatment? So most of these creams, except hydrocortisone and fusidic, permethrin, benzyl benzoate, and malathion are indicated in scabies. But for the face, permethrin is the recommended treatment. Right? So our answer is A. Then, so hydrocortisone is not indicated unless there's coexisting eczema. Fusidic acid is not indicated unless there is secondary bacterial infection. Then next question. A 2-year-old boy was referred by the MOH for further evaluation of murmur. On examination is pink. That means child is not cyanosed. Yes. Grade 4 ejection systolic murmur best heard at the pulmonary area, which radiates to back. So ejection systolic murmurs in pulmonary area could be due to 3 reasons. One is AST, one is pulmonary stenosis, one is high-lying ventricular septal defect. But the murmur which you can hear at the back is almost always due to pulmonary stenosis. In AST, you don't hear the murmur in the back. And also, murmur is not that intense in AST. This is classical pulmonary stenosis murmur. So, then question number 14. A 4-year-old boy with attention deficit hyperactive disorder possesses multiple bony fractures. The orthopedic team refers to the child. So, yes, wording is wrong here. The orthopedic team refers the child to the general pediatrician to evaluate for possible NAI, non-accidental injury. Which of the following fractures is highly likely to be NAI? So out of fractures in your illustrated pediatrics, it will say highly likely fractures, intermediately like fractures, and unlikely fractures. So out of these fractures, so any fracture in the mid part of the long bone is highly likely to be accidental. But any metaphyseal fracture is highly suspicious, right? Posterior fractures and metaphyseal fractures are highly suspicious of non-accidental injury. So metaphyseal, refer to the table in Illustrated Pediatrics. It it will give you a very good account on the child abuse, right? Definitely, there will be at least one best of 5 MCQ from child abuse, right? Then the last question. A baby boy was born at a term following normal vaginal delivery. His antenatal scan revealed bilateral hydronephrosis without dilated ureter. So that is very important. So this dilatation is not due to vesicular-ureteric reflux. This finding was confirmed by a postnatal ultrasound scan. What is the most appropriate next investigation of choice to arrive at the diagnosis? So what is the likely reason here?
PUJ obstruction.
Yeah, periureteric junction obstruction. So PUJ obstruction. So in that case, you have to demonstrate PUJ valve obstruction by showing that some sort of a dye is not going beyond that level. Oh, this SMSA, there's nothing like this, so it has to be DMSA. So DTPA, DMSA, HIDA scan is not for renal imaging. MCUG is to look whether there's vesicular reflux, and IVU and DTPA are the choices. But we don't routinely do IVUs in children because IVU carries lots of radiation risk. But the DTPA is an alternative. You can't differentiate if there's MAC3 scan. It's also correct. That's why I have not given MAC3 scan. In that case, you will not be able to differentiate which one, because in abroad, rather than DTPA, they use MAC3 scan. But what we do here is we use DTPA. So that's it. But out of bilateral periureteric junction obstructions, around 10 to 15% of these children can have vesicular reflux as well. So some of them might need MCUG as well, right? Right. So that's it. Any questions?